Model Early Intervention and Training Center at AIIMS Jodhpur. He has been involved in manpower training and capacity building of healthcare professionals across India in the field of early detection, holistic intervention for the infants and children with neurodevelopmental disabilities. He is a former senior consultant to a health project, child health project, Rashtriya Bal Swasthya Karyakram of Government of India.
Oh my God.
He is author of an atlas, Child Development, Typical and Atypical. He has a wealth of experience, and we will be listening to him and gaining from his vast experience. So over to Dr. Asis Kumar Ghosh, please. Stage is yours.
Good evening, sir. At the outset, I would like to express my heartfelt thanks to the executive member of Indian Academy of Cerebral Palsy and the esteemed members who are present today on this webinar. Would you please show me the first slide, please?
Just 1 second, Dr. Okay, Ashish. Now, are you able to see?
Yeah. Yes, yes, sir. Yes, sir. Yes, sir. So, to begin with, I will start the definition of cerebral palsy, because if we can understand the definition of latest, cerebral palsy, then we will be able to understand that what should be the best practices and what is the best practices of cerebral palsy. So, yes, sir. So, yes, sir. Okay, sir. Thank you. So, could you please click on to the previous slide?
Tell me, I will operate. Nothing
the
to
definition. Okay, so the definition of cerebral palsy says that it is a disorder of movement and posture caused by damage to the fetal brain or the immature brain, and it is the disorder of movement and posture which is associated with other associated problems like cognitive impairment and other hearing impairments and other impairments. So, when we will discuss the physiotherapy for children with cerebral palsy, I think that we should mention that cerebral palsy is not only a motor disorder, but also it is accompanied by other disorders like speech disorder, cognitive disorder, and other disorders. So, when I will be talking on the slides, I will also mention that why should we totally not eliminate the intervention, the approach which involves the other activities as well. So along with the motor activities, the other activities like to improve the child's communication skills, cognitive skills, we need to focus on. So before we go into the treatment or management of cerebral palsy or physiotherapeutic management of cerebral palsy, let us see how do we know that this child has got cerebral palsy? Because we need to first know and detect and confirm the diagnosis of cerebral palsy. So the best evidence, best available evidence says that the infant can receive the diagnostic specific early intervention and the surveillance to optimize neuroplasticity and prevent complications, and the parents can receive psychological and financial support. So what happens is we get babies or children from two different streams. One is from the newborn detectable risks, which is from birth to 5 months of age, and then the child, the infant, detectable risks. What happens is babies who are born with certain complications like encephalopathies, asphyxia, and other things, they are generally admitted immediately to the neonatal intensive care unit. And when they come out of the neonatal intensive care unit, we start doing a surveillance or try to see whether this baby is developing in a normal trajectory. So that can be detected within 5 months, and we can start the intervention immediately then and there. And another way of detecting the infants is when the parents or the caregivers, when they see that there is something wrong with the child, the child is not learning the milestones, or the child is unable to stand at around 9 months of age, the child cannot use both hands. So what happens is, you can start the diagnosis, first the detection and the diagnosis. Now the early diagnosis, newborn diagnosis can be done through a combination of tools. One is general movement assessment, and another one is, and along with that, you do an MRI and try to corroborate whether there is any problem. Generally, by 3 months of age, through general movements, we see the fidgety movements when the child automatically moves and the trunk is also involved. So if we see that movement is coming, then the fidgety movement is there, then we say that there is no issues. But if fidgety movement is not there, then we start intervention. So the next slide, could you please show the next slide? And from 5 months to 24 months, we see infants, and we do a further assessment for these children. So why do we assess these children at an early age? Because of the neuroplasticity. The brain develops very fast. The new synapses are being formed. So we take this opportunity of these 2 years of critical window period. So first thing is, we try to utilize the maximum advantage of natural neuroplasticity that happens, and that happens in the damaged brain as well. New connections can be formed bypassing the damaged neurons. So that is our main objective, to start the treatment early to get the best results. And so it is moving very fast, sir. Slowly, yeah. So the next slide, please. Yes. So the general movement assessment. So could you please go back to the previous slide? Yeah, general movement assessment to identify motor dysfunction, and it has got high predictive value of cerebral palsy, which is 95% to 98%, which is combined with neuroimaging. Again, MRI brain, 80% to 90% predictive of cerebral palsy. And we can also use standardized neurological assessment, which is called Hammersmith Infant Neurological Examination. Well, if we get the score at 3 months below 57, which is highly predictive of cerebral palsy, equivalent to 96%, and the standardized motor assessment, this is another test which you can do, which is test of infant motor performance. Next slide, please. Sir, can we move to the next slide? Yes. So early detection of cerebral palsy from 5 months to 24 months of corrected age. So what are the tools we can use? We can use standardized neurological assessment, again HIND, which is 90% predictive of cerebral palsy. And the score, if the score is below 40 at 6 months, 9 months, or 12 months, is almost always indicate cerebral palsy. Again, combined with MRI brain and standardized motor assessment we can use, which is known as Alberta Infant Motor Scale, 86% predictive of an abnormal motor outcome. So next slide, please. Sir, I have done this one. Can we move on to the next slide, please? Yes. So why physical therapy interventions? And what are the best practices? The best practices, why? Because again, synaptogenesis and the strengthening of synaptic chain. You send the same information through the new synapses that are formed, and it is driven by motor cortex activity to develop the motor system. If we look at the typical development, we will see children, when they develop typically, it is activity dependent, and at the same time, they are activity seeking. Whenever they see something, they learn how to row, they learn how to crawl. So the activities continuously increase. And what type of intervention we should give? We can only give early active. Sir, can we go back to one slide? I think it is in the previous slide. The early active movements, yes, only early active movements facilitated by head and trunk control. Now, let me tell you here that we do not do physiotherapy for arms and legs. We do not do any passive movements of arms and legs. We do not stretch spastic muscles because those are not active. It is only the active movements that are being registered in the cerebral cortex, and in our treatment, we make the child sit, we make the child stand, we try to improve the postural control, which means the child should have head and trunk control. So it is the whole body activity. Physiotherapy for cerebral palsy is not for the ankle or the metatarsal joints or the wrist joint, not for the elbow joints. You know, it is a kind of movement as a whole, and movements are only possible when there is enough postural control. The child is able to sit, child is able to stand, child is able to do other activities, even with some supported device or a special chair. So if we can make the child practice active movements, then new cortical connections will be formed. And if we miss this period, especially the first 2 years of age, then we will miss those connections, and it is therefore it is said that you use it or lose it. So next slide, please. So here I have shown two examples, kept two pictures here. The child is actively reaching out to the balloon. This child also has certain vision issues, so that is why we have used the high contrast patterns. And on the right hand side, we can see it's a simple LED which is being wound around a kind of wooden bar on his table, and the light is switched off, and the mother is working with the child. So the child is reaching out. So you can see the physiotherapy is actually how to facilitate active movements using vision, hearing, and other sensory modalities. Next slide, please. This one is a video. Sir, can you please run the video, play the video? Yes. See, by using a simple bolster, a round pillow, and if you tilt the child to one side, the child will try to right his head and trunk. The child has used a very nice thing. The child used both the arms for protection. And you can see the child is clearly turning all writing reactions. This is one of the methods of improving child's head and trunk writing, head and trunk control. Next slide, please. Next slide, please. So the infant's motor behavior through exploration of and interaction with the environment, which is very, very important. It is both human environment and the material environment. Controls and generates the growth and development of muscles, ligaments, and bones, as well as driving ongoing development of the neuromotor system. So the child's brain is learning new activities just by, improving the environment, talking to the child, and it also improves the child's musculature, the ligaments, bones, the entire neuromusculoskeletal system. Next slide, please. So again, here I have kept two photographs. You can see the mother is holding the child and the child is encouraged to reach out. And these are very simple toys, play materials. You do not have to buy very expensive toys from big shopping malls. Very simple things, these are some bells. The moment the child is touching, the child is getting the sound feedback. On the right hand side, the mother is holding the child, helping the child to keep the head upright. You can see, and helping the child to feel the flower. So this is how you can enrich the environment, and this has a huge impact on child's developing neuromotor system. Next slide, please. So why cerebral palsy is specific? Why do we give physiotherapy or physiotherapy treatment? Because treatments and long-term musculoskeletal outcomes differ and minimizes deleterious modifications to muscle and bone growth and development. Now, this, if we consider that, the child has been detected with cerebral palsy and we haven't done anything, or say, for example, we are doing some passive movements for quite some time with the child. So what happens is, the child will not be able to learn. And what will happen? The child will stop moving at some point, and that will cause the secondary musculoskeletal problems like developing contractures, no movement. It will increase spasticity, and it will have long-term effect on the breathing pattern. The child may have feeding issues, deglutition issues, which would further cause aspiration pneumonia. So you actually invite a slew of complications for the future. So cerebral palsy specific, I will come to the next. What should we do about it? The specific early interventions maximizes neuroplasticity. The more the child moves, and the movement has to be context-based. I will discuss that later on. And the child's overall development, we will be able to see. Next slide, please. So we can get two types of children. One is if you find the child is unilateral, one half of the body is not functioning as equal to the other half. We call that hemiparetic cerebral palsy or hemiplegic cerebral palsy, who receive early constraint-induced movement therapy, which means we restrict the good hand by putting a sock into the good hand, and in fact we force the child to use the affected side. We keep small toys, we keep some dry food in front of him so that the child learns. So internationally, the maximum doses is you can do it for 15 minutes 2 times a day. So this is called constraint-induced movement therapy, when you restrict the child's movement of the sound side and force the child to use the affected side. Infants with bilateral cerebral palsy, nowadays we don't use the terminologies like spastic quadriplegic or spastic hemiplegic. We use bilateral cerebral palsy as per ICF definition, who receive regular intervention have lower rates of hip displacement, contracture, and scoliosis. These are the long-term musculoskeletal complications children with cerebral palsy have. Next slide, please. So infants with any type or topography of cerebral palsy who receive goals activity motor enrichment, which is also known as GAME, which is an early, intense, enriched, task-specific, training-based intervention at home. And research has shown us that they have better motor and cognitive skills at 1 year than those who receive usual care. Now let us explain each and every word. Goals can only be formulated if we assess the child thoroughly. We begin our assessment by taking the daily routine of the child, how the mother is handling the child, how the mother is feeding the child, what is the kind of posture that in which the child plays. So we have to do a thorough assessment for each and every child, and we will have to formulate a goal, and that goal needs to be shared with the parents. And that goal needs to be pursued through specific activities, through motor enrichment, like you hold the child on your lap in a straight position on your thigh. Why do you hold the child in that position? Because if the child has got adductor spasticity, you need to inhibit that adductor spasticity. So sitting astride on a bench or on your leg actually inhibits the hip adductor spasticity. Now, in this posture, what activities you can do? You can hold a toy within the reaching distance and encourage the child to reach out, in different directions. So that is the kind of activity which the parent will see in front of you when you will be doing therapy or motor intervention with the child. And why this has to be early and intense? Because we need to use the critical period, 2 years of critical period of neuroplasticity. And you do not have to do physiotherapy throughout the day. This therapy can be done through play activities, through caregiving activities. So each and every activity you need to show to the parents that how they can make the child do all these activities. So why at home? Because neuroplasticity says that you will have to practice the same movement again and again. So 24 hours, it is not possible, neither it is feasible for the parents to do quote unquote physiotherapy. But same activities can be done at home in different activities and by different caregivers. By caregivers, I want to mean that it is the grandparents, maybe the uncle or the aunt, and of course, the parents as well. So if this can be done through play activities, through caregiving activities, you get better results. So improvements are even better when the intervention occurs at home, because at home, the children are most relaxed. When they come to a clinic, when they come to a hospital, it's a new environment. When they see the physiotherapist or an occupational therapist, with a new person for that baby, for that child. So it is always good that if we can train or coach the mother or the father, that so that the carryover can be done throughout the day. Next slide, please. So it has to be task specific. We need to give some task for the child for motor training, like reaching out for different objects, reaching out for a ball. When a child reaches out for a ball and can hold a ball, the child uses one type of grip. When you show a glass, the child reaches out for a glass, and glass requires different kind of grip. So it is the task specific training. That means while during meal time, while feeding the child, you can train the child for certain activities, like holding the spoon. If the child cannot hold the spoon properly, make it a thick handle spoon by giving, by attaching a kind of wooden handle to the existing spoon. So this is how you can do it. And this task specific motor training, the child retains. Okay, child keeps it in the brain for learning, and that has to be done throughout the day. And let me tell you that though I have said that it is a new paradigm, but this is the paradigm, it has to be there in order to support neuroplasticity. Like doing passive movements for a child with cerebral palsy is just wasting of time, and you can do certain harm if you suddenly stretch the spastic muscles. The muscles become more and more stiff. So you need to hold the child, put the child in a comfortable sitting position or a standing position, and give some activities. Next slide, please. So what should be our aim of early motor intervention? To optimize motor, cognition, communication outcomes. We do not do physiotherapy, only physiotherapy with the child. We ask the child that, can you reach out for this? Look, this is a ball. So child uses vision, child understands your language. So the child's cognitive abilities improve. The child tries to speak or tries to use other mode of communication like augmentative and alternative communication. So through therapy, through quote unquote physiotherapy, we are actually promoting the overall child development. And it also prevents the secondary impairments and minimize the influence of complications that worsen function. If the child develops contracture, these threatening contractures, the child will stop functioning after some time. So active movements helps in different ways. To promote parent and caregiver coping and mental health to reduce stress. When you demonstrate therapy to the parents, you need to handle the child, you need to play around, you need to find out that what works best, what is the child's best comfortable posture. So until and unless the child assumes a comfortable posture, the child will not be able to use his limbs, be it the hands, arms, or legs. And when they see you, when the parents see you, the caregivers see you working with the child, and they see some results in one treatment session, they feel happy, they feel relaxed. So please tell them that, I am doing this. So can you try? Can you hold the child in this way? So it's a kind of constantly, communicating with the parents and help them to understand, because in giving lip service, days. It really, so instead of giving lip service, you will have to work very actively with the child, show it to the parents, take the parents into your fold and help them to learn. Please tell them that instead of what you are doing or what you will be doing, you need to explain why this has to be done. So when the parents understand that why this has to be done, the parents will naturally will go back home and will try all those things. Next slide, please. So here you can see the two task-specific activities. On the left-hand side, I make the child stand, the mother is sitting behind, and what the mother is doing, mother is showing a toy, and the child is trying to reach out. So your physiotherapy is being done. Don't think that this is not physiotherapy, because often parents ask me that you will not do physiotherapy with my child, because everywhere the prescriptions are being done like physiotherapy, occupational therapy, speech therapy. So you need to combine all these therapies and give the parents a comprehensive program where there will be communication component, cognition component, motor component, everything. So here you can see the best way. This is the best practice. On the right hand side, you can see I have put the child on his tummy. Why? Because on a towel roll, just to eliminate the force of gravity and to facilitate head control. But at the same time, I'm showing a particular toy to the child to get him engaged, visually engaged, and lift the toy so that the child lifts head. So actually here I am working for head control, trunk control, weight bearing on forearms. At the same time, I'm working for visual engagement. Next slide, please. So we need to come to a conclusion that motor learning, and what is motor learning? Motor learning is the relatively permanent change in a motor skill achieved through practice or experience, which I have been telling you throughout, which can then be transferred to new learning situations. It is based on child and task-specific factors in order to promote motor learning, which means the child needs to do some active movements, and those active movements should be context-based. Say, for example, while bathing, you want the child to pour water with a mug. Okay, so you need to put the child in a stable posture in the bathroom and work with the child, help the child to pour water. So this is what we call context-based. Child is learning a particular skill, motor skill, and at the same time, the child is performing a particular activity. So the child, and it has to be child and task specific. You can do the same thing during meal time. You can do the same thing during play activities. So you need to apply motor learning. So motor learning approach says it has to be context-based, goal-oriented activities, learn skills that can be transferred to real-life activities. I'm giving you an example. All of us know what pincer grasp is. It is tip to tip, index finger and the tip of the thumb. But if you want to train the child to put on the button into the buttonholes, the child will be using the same pincer grasp, but the skills are different, the activities are different. So you need to think about what sort of activities you will think of so that you can improve the child's functional skills, and that needs to be incorporated in daily care activities for carryover. Parent involvement in goal planning and intervention. You empower the parents, let the parents think that how this can be done, how the shirt can be worn, what position should I find out for the child to make the child independent, just to put on a shirt or to put on a pant. So we need to coach the parents. We need to tell the parents that what you are doing is absolutely fine, but if you slightly modify the task or the activity what you are doing, the child will be able to perform better. So now we have stopped giving instruction to the parents. So nowadays we are using the term coaching the parents. You see, coaches do not play on the field, but what the coach can do, coach can give certain suggestion to the parents so that the parents can do those activities with the child. Next, please. So if you see to retain, this motor learning helps the child to retain the motor skill after a period of time. Probably the child will not practice that, but still the child will be able to retain. And sir, next slide, please. Thank you. So parent involvement in goal planning and intervention, and coaching parents to modify task setup, and engaging the child in that particular task. And then the retention comes. So next slide, please. And the same activity can be transferred to other activities, new activities as well. So that whatever the child has retained through the practice of that particular certain activity, and that can be transferred in other activities as well. Next slide, please. What we need is child's participation. Child needs to participate in what we do, to extent to which the child participates in physical and mental practice throughout the session. And you need to show this to the parents that the child needs to be active enough to learn. Next slide, please. Say, for example, you are teaching the child to button and unbutton a shirt. So what we say, you help the child to learn to put the buttons into the buttonholes, all the buttons. It is not that just one button you can just say and then say, okay, we will do it next day. So you will have to finish that activity so that the child's learning is complete. So tasks are practiced as a whole skill rather than breaking the task into components. In some cases, probably, according to child's motor severity, we need to break up into certain components, but try as far as we can use this as a whole. Next slide, please. So it has to be a variable practice. What is that? Rather than constant. Like, you are helping the child to learn to reach out or hold something. But the thing is, you need to bring in certain variation, novelty. You change the play material, or you can change the child's position. Child is playing in a sitting position. You can put the child in a standing position and play. So variation, bring in variation. It could be the position of the child, it could be the type of movement, it could be the type of toy or the equipment what the child is using. So you need to change that. Next slide, please. So, random practice. Block practice. Suppose you are teaching a particular activity, like putting on pant or putting on a shirt, instead of doing it for half an hour or a 20-minute session, what you should do? Okay, once the child has put on his pant and shirt, you make him play in other activities. Then you again come back to that particular activity. You can then work on taking off the pant, taking off the shirt, and again put it on. So that is why it has to be done anytime during the day, not for continuously for a certain period of time, but it can be done in through different activities and during different times. So it involves returning to practice a task within a single therapy session after working on at least one different task. Next slide, please. And you gradually progress. You bring in more complications. Like a child is doing, he's putting blocks one after another. So it may be 2 or 3. Then you try whether the child can make it a tower with 4 or 5 cubes. So, and these are all physiotherapy, mind you. The child will be holding, the child will look at the position where the child has to put the block. So it's a kind of activities that will improve the child's cognition as well. So the child can make a tower, a child can make a train with the blocks. So you bring in variation and you progress with the task. Like you can give a simple shirt and button the shirt and tell the child to unbutton the shirt and see whether the child can unbutton his own shirt. So that is how you need to progress. And that also requires cognitive demands. Next slide, please. So here is the role of physiotherapist or the therapist. I am not using the word physiotherapist only. Any therapist, even the parents can do this. The therapist should demonstrate. Instead of giving them lip service, you need to show it to the parents. This is how it has to be done. And then only the parents will do. Because there may be confusions. If you tell them to do this and that, they might be confused. What shall I do? So if you demonstrate what is to be done, it will become very clear to the parents. And you be the model that how this task should be done. And that has to be done within the therapy session. Next slide, please. So you need to give physical guidance. There are 2 kinds of guidance. One is physical assistance. You really hold the child to, help the child to hold the spoon, scoop the food, take it to the mouth. And then what you can do? You can just give a physical prompt. Just touch the child, say you hold the spoon, scoop and take it to the mouth. So you give a physical prompt. And then when the child can do this, will learn, then you can only use verbal prompts. So this is how you can give guidance. It could be physical guidance or verbal guidance. So handling either facilitation or inhibition for the purpose of executing or learning a task. Next slide, please. So these are 2 videos. Sir, if you could play the video first on the left side. See what I am doing. I am helping the child to weight bear and then helping the child to reach out for the toy. So what is happening? The child is weight shifting on one side and reaching out with the other. And you can do it with the other hand as well. And look at the mother is working with me. That is what you get the active cooperation from the parents. This is called physical guidance. You help the child, let the child think of the kind of movement he or she is supposed to do. See, from that prone position, I have put the child in a standing position. So it's a kind of new position the child is in. Sir, could you please run the video on the right side Thank you. So at the end of the session, I have put the child in a side-sitting position. I have given him 2 small beads, and I want the child to, you can see this, is trying to reach out, trying to touch those small beads. Of course, you need to give support because this child does not have enough control over his sitting. So again, here the family member is being actively participating in this activity. Next slide, please. So while doing this, you need to permit errors as part of learning. Don't stop the child if the child does any wrong pattern of movement. You need to go slow. Let the child first move, and then slowly and gradually you need to correct the pattern of movement or correct the posture. So gradually you decrease physical guidance, you give initially verbal feedback, and then you gradually reduce that and allowing the child to figure out a movement. Everything boils down to learning a movement. Physiotherapy leads to learn the functional activities, functional movements. The physiotherapy will have no meaning if there is no functional improvement. Next slide, please. So recommend practice outside therapy. A child's life cannot be guided by physiotherapist or occupational therapist or the therapist alone. Please tell the parents that take your child for an outing, give him different kinds of toys, expose him to different kinds of environment. So asking the child to practice a task mentally or physically outside of therapy time. Let it be a play session for the child. But you need to keep in mind that, what is my goal? What is the child's goal? What the child is supposed to do? So that they can do all these activities with some meaning. Next slide, please. This is probably the last slide, which says you need to train the caregivers or coach the caregivers, provide information about the child's condition, what the child can do, their immediate task performance, or instructions about components required to complete the task. So every therapy posture, every therapy movement should lead to a certain task or activity. For reaching out, holding a toy, holding a glass, holding a spoon. So every activity should have a meaning. So therapy should have a meaning. It should not be a therapy session or quote unquote exercise session. You see, a child cannot do exercise like us. They cannot go to gym. What is the difference between exercise and intervention? You see, intervention leads to development. We call this as child development. A child cannot lift, a toy 10 times. No, child cannot lift a heavy lifting for 10 times. No. So what you need to do is you train them that the child needs to do these activities in order to learn certain activities. So there is no exercise. Exercise we do for a limited period of time, but the therapy has to be carried over throughout the day in different activities. Next slide, please. So that's the end. Thank you very much. For your patient hearing. If you have any question, please ask. If you have any comments, suggestions, please.
Thank you very much, Dr. Asis. I'm sure there must be many questions in the minds of some of the participants, and some of the questions have been raised and written down in the chat box also. So if the organizers feel, they can read some of the questions one by one as they feel appropriate, depending upon the time that is available. Thank you. But I have one question, if I am allowed to ask.
Yes, sir, please.
See, many a times the child with cerebral palsy may be constantly crying
Yes, sir.
for many possible reasons, one of which may
Yes.
be colicky pain in the abdomen. So it is very difficult to make the child do the exercise or expect the attendant mother to perform the exercises. So I feel it is very important
Yes, sir.
for the therapist to understand the
Sir, the
situation.
answer
and
to your very important question is physiotherapy, occupational therapy should not be painful. So one way we can say that, it should be rather joyful for the child. If the child has any other medical issues, we will definitely refer the child, we will take the child to the doctor to address those issues.
over to the organizers, please.
And also, I am very reluctant to take the child away from the parents' lap or from the mother's lap because they knew a new face, a new hand. So we try to tell the mother that hold the child in this way, and we try to make rapport with the child. So our therapy sessions should be joyful rather than painful. The child should not cry if the child does not have any other medical issues. Any question, please?
I think Sheenu will
Sometimes-
present questions. Is Sheenu is there?
Yes, sir. Sure. Yes, sir.
From
Sir, we
chat?
have few of the questions in the chat box. The first question posted here is that what therapies can be done for babies less than a year old who can't follow instructions?
5-year-old or 5 months old?
Sir, a year old, 1 year old, less than 1 year old. So what can we do
1 year old.
if they? Yes, sir.
Okay. 1 year. Okay. So as I have already mentioned, we do therapy in such a way that we get some response from the child. Like you can use a bolster, put the child on his tummy on the bolster, and then gently tilt to one side. What you are looking for? You are working on vestibular, you are working on writing, head writing, neck writing, trunk writing reactions. Similar way, I have shown you a video where I have put the child in astride position over a bolster and tilt the child to one side so that the child tries to regain the midline. So this is to improve the child's equilibrium reactions. So, and a 1 year old child will definitely can be encouraged by showing different toys. Tell the mother to talk to the child if the child doesn't respond to you because it's a new face. By that time they develop stringer anxiety. So naturally, so you don't have to instruct. You will have to put the child in certain positions so that you can extract certain reactions which are innate. As I have mentioned, that we do not do physiotherapy or occupational therapy for the limbs. No, we don't. We treat the whole child. So what is the main pair of our body? Head and neck, shoulder and trunk and pelvis. So we need to stabilize that first and then encourage the child to move. The child does not have to understand your instructions, but through other ways, by attracting the child with different kinds of toys, put the mother in front of the child and tell the mother that you play with your child, I am sitting with you. So I'm sure definitely this can be done. You can you can start therapy intervention even with a 1-month-old child. I mean, that's what we do. We don't wait for 1 year, the things becomes very florid. Cerebral palsy become actually ripe. No, we don't. We consult our neonatologists, we consult our pediatricians. They tell us, well, there is some problem in the MRI as well. We do the physical assessment, motor assessment. We look at the child's posture. We look at the child's quality of movement. We start the treatment. We start the intervention. We start the intervention in mother's lap, in the father's lap.
Thanks a lot, sir, for answering. The next question in the chat is that what should we do if spasticity or high tone has already developed in the child?
Okay, I mean, this is a situation. I can imagine that if the child comes to me at 5 years or 6 years or 9 years of age, what I have emphasized is early intervention, because early intervention helps you not to develop all those conditions. Even if it develops at a much later age. So if there is high tone, if there is high postural tone, we need to find out in what particular posture the child can be placed, either in sitting or in standing or in sideline, so that you inhibit the spasticity. Spasticity itself is not a problem. Spasticity manifests itself through abnormal patterns of movement. So by inhibiting, by keeping a pillow in between the legs, in between the thighs, you inhibit hip adductor spasticity. By, you make the child sit on your thigh in a straight position and then walk for trunk control. So on one hand, you are using, on the other, it makes sense? Here lies the importance of choosing the right furniture as well. A therapist has got the duty to find out the right furniture for the child for better function. By doing passive movement and passive stretching, you rather you can use certain things like gaiters to keep the flexor tone of the elbow or the knee, to keep it checked, or you can use the right furniture, carry the child in right positions. All these things matter.
Thank you, sir. The next question is that is there any specific age for till what neuroplasticity works?
Neuroplasticity works throughout your life. Even for us, throughout our life, neuroplasticity continues. Once upon a time we started writing, now we are using typing. It's a kind of new skill. So our brain is like a plastic material. Neuroplasticity is you keep on changing the task, and your brain will, the neurons will learn how to adapt that new task. So neuroplasticity continues, but enough evidence is there, scientific evidence is there, that first 2 years of life is huge amount of neuroplasticity that takes place. Neuroplasticity is nothing but formation of new synapses. You are born with 100 million neurons, and there are 100 billion neurons, and there are 100 trillion connections. So how you will develop your connections, it is up to you, what sort of activities you will be doing. So neuroplasticity continues, but first 2 years, if you miss that chance, it is difficult then, because by that time, the disability sets in. Say, for example, crossing of legs or asymmetrical tonic neck reflex. You did not intervene. You waited till 2 years, 3 years of age. What will happen? The child's neurons have already learned that crossing as a natural movement, as a normal movement, or ATNR as a natural reflex. But the thing is, if you inhibit, the day you are seeing it, that is why your assessment is very important. The time you see that this is affecting, this is hindering the child's motor development, then you need to inhibit those particular activities and facilitate. That means you are sending the messages of more normal movements to the brain before the child's brain learns wrong movement patterns. That is the beauty of early intervention, to catch them young. And you teach them before the child learns wrong movements. But neuroplasticity continues throughout life, whether it is in a bad way or in a good way.
Thank you, sir. The next question is that what is the role of psychologist in therapy sessions of less than 1 year child?
It's a very good question. The psychologist should sit with us, or we should sit with the psychologist, because let me tell you, psychologist can guide you what sort of play activities, new learning has to be done. As the children grow, they learn new activities. So it could be cognitively driven activities. It could be other activities, play activities, functional activities. So psychologist is there to guide us that, well, the therapist is holding the child in this way. So can I help the child to do certain activities which requires your cognitive skills? So whether it's psychologist or physiotherapist or speech pathologist, whoever it may be, if we learn how to handle a child and give the parents a comprehensive program, I think that is the crux of it. So, you do not have to send the child, because till 1 year, what sort of development we can think of? Cognitive development. The child will know you, child will play peekaboo with you, child will, do certain movements, walking, all these things. But, you just introduce, you take the help of the child and find out what the child is not doing cognitively and why this child is not doing, where is the problem. You will also help the psychologist to learn how to do certain activities in certain positions. Like if the psychologist says that the child needs to learn yellow color or red color, or the child needs to learn, what is the name of this object. So I will tell the parent, okay, you buy a red ball or a yellow ball, give it in the child's hand, play with that particular ball. You can roll the ball, spin the ball, drop the ball, and you can keep on talking to the child, improve the child's vocabulary when you are doing therapy. So there lies the role of psychologist, who will constantly guide me what next. Because my therapy is not only for just movements, but also for some meaningful movements, which will ultimately lead to functional independence.
Achha,
Thank
we'll
you,
take
sir.
one more question. That's the last question. And we request
Yes.
all the participants can directly send the questions in a WhatsApp so that we can present it to the speaker and Ashish, or you can email to
Yes,
him, and
of course.
most of the time he is available, so that you can ask him questions directly. It is getting late, and um, one question: can you explain the management of spastic quadriplegic, GMFSC 4 or 5? Sherine, I think.
Well, I mean, let me answer this question, sir. First of all, when we start therapy intervention, we don't think in our mind that whether the child is in GMFC 5, GMFC 4. We need to see the child's problem, and that what my assessment will tell me that what immediately has to be done. There is no such different physiotherapy for GMFCOS 1, GMFCOS 2, 3, 4, 5. No. You have to see, because GMFC 4 and 5, they will not be able to walk. But it doesn't mean that you will not do physiotherapy. It doesn't mean that you will do passive therapy for the child. I would rather suggest you that you think of a customized chair, make the child sit comfortably there and work, because this child may not improve physically, but the child's cognition can be improved. Child's other activities can be improved. So we do not restrict our physiotherapy as such for different grades, because that is why the importance of assessment comes in. You need to assess the child thoroughly and see what goal you can set. Naturally, according to the child's motor severity, your goal will have to be set according to that. So don't keep that thing in mind when you will be treating a child. Try to do something so that we can retrieve certain activities, optimally, because we don't work for normality. As much as possible, at least I will be able to make the child sit in a comfortable position in a particular posture. I can show the parents that, this is how you feed your child. I can tell the parents that, you can keep a toy in this way so that the child looks. So physiotherapy should not be restricted to spasticity itself. It is the child development as a whole. I cannot give you any recipe, my dear friend, because there is no recipe for physiotherapy for children with cerebral palsy. I cannot give you a list of exercises. No. It has to be a holistic approach where communication, cognition, everything will be there. Social emotional development, everything has to be there. Sir, would you like to add anything? Your experience, your life experience, you can share, because I, as a physiotherapist, I strongly believe a child's life cannot only be guided by a physiotherapist. Child should lead a life as normally as possible, as joyful as possible.
Thank you so much. You have shared a lot of information, and I am sure it has helped many of the people who have logged in today. I wish there was more time possible, because there are still many areas which have been left uncovered, as is likely to happen in a topic as big and as vast and as complex as cerebral palsy. But I'm thankful to you. You have covered the topic in a very simplified way, in a very comprehensive way. And I'm sure there will be opportunities to listen to you again in some time nearer future. But what is important now is that transition of the child with cerebral palsy into adolescent stage. That is where the challenges are different. And we need to be prepared for that. and we
Yes,
need
sir.
to prepare the parents for that also.
Yes.
So the challenges will be different in different
Exactly,
stages,
sir.
and it is a life cycle approach.
Yes.
Many a times, my experience has been
Yes,
that
sir.
people think
Absolutely.
only in terms of childhood phase, but it is a
Absolutely,
lifelong
sir.
condition, and we need to be adaptive, and we need to be ready to modify. And it is a
Yes, sir.
team. If a therapist thinks that he or she only can handle everything, that will be a wrong idea.
Yes.
So it is a teamwork, and we
Yes.
are all members of the team. And if we
Absolutely,
are
sir.
working in a way that the child or the person with cerebral palsy and his or her family is at the center of our discussion and planning and execution, we can do a lot good instead of trying to
Absolutely.
preserve our domain and enhance it further. So I am thankful to the platform given to me today to listen to you and to listen to the questions which have been put in by the participants in the chat box. And I wish to join in future programs also, if possible. So I am thankful to the opportunity given to me by Dr. K.D. Mallikarjun, my dear friend, for many years now. And I will rest my observation at this, but I want to congratulate the speaker and ISCP for this wonderful academic program. Thank you.
Thank you,
Thank you,
sir.
sir.
Thank you
Thank
very
you.
much. And Trupti, I think she will share a vote of thanks on behalf of Indian Academy of Cerebral Palsy. Dr. Trupti?
Yeah, yes, sir.
Yeah.
Was
Yeah,
sentence